there's a little static there.
Again for interrupting. It seems like he's breaking up.
Mr. Brown, you're breaking up a little
Yes,
bit.
sir. Yes, I think the call is breaking up. Give me a second here. Is that clear or is it still breaking up?
It's still breaking up.
Give me a second. I might have to try to switch audio. Give me just a moment here.
Mr. Brown, we have IT on the way to you right now.
Mr. Chair,
Yes.
Mr. Shakifi, actually, I was going to say it sounded like the entire call was breaking up, but now Mr. Brown is on mute better, so that's fine.
Yes, I think, yeah.
I can't hear Ms. Newton
No.
either.
Yeah, Ms. Newton is breaking up a little too. So must something on the whole system seems like.
Yeah, Mr. Livingston, actually, I stand corrected. The whole call is breaking on me, and I'm actually connected on audio via my phone, so I shouldn't be affected by any mobile issues. I'm not sure what's causing our problem.
Yes, but everyone is breaking up, yes. So IT is checking on it now.
I can hear you clearly, Mr. Livingston.
Well, that's interesting. And Ms. McBride, your voice coming across clear too.
You think we can take care of housekeeping?
Well, I don't know if we may get left out of the important housekeeping.
Oh, they can't hear either? I thought they just didn't come across.
Mr. Brown.
Mr. Livingston, we have IT in the conference room with Mr. Brown and staff trying to work out the audio problem.
All right, thank you.
Mr. Chair,
Yes, go ahead.
while IT is working with our administrator, I'm also going to disconnect from the audio and reconnect and hope that that helps.
Okay.
Mr. Chair,
Yes.
while we're waiting, just a quick question. Am I correct in that there are no backup documents for this meeting?
You're correct. The only thing I think you might have had with your minutes, with the agenda was your minutes.
I have the minutes, but I don't have any backup documentation. Okay. Thank you.
Yes.
For those of you who are just joining us, we are experiencing some audio difficulties. Our IT department is in the process of working that out.
Kimberly,
Yes, ma'am.
I just wanted to see if you can hear me. We're using
Yes,
my
ma'am.
computer's audio, so.
Yes, ma'am. I hear you perfectly clear.
Dr. Bell, this is Yvonne McBride. I'm so glad to see you here.
Thank you.
Welcome.
Forgive me for joining late. I was trying to jump off another call and had to find the meeting invite, but I'm glad to be here.
Well, welcome. You're late. We have a little technical difficulties, so you're on time.
Okay.
Chairman Livingston, can you hear me, sir?
Yes.
So right now, while we're trying to work this out, I think it'll be prudent, since you have so many folks on the call, if you would go ahead and introduce our special guest. I'll just speak to the committee briefly and just let you know that during the committee the last meeting we had, we heard that there were opportunities for us to bring in public policy experts, medical experts. And so we reached out to our local contacts. And so we have on the call several special guests. I'll turn it over to Chairman Livingston to introduce those guests and to begin the process. Go ahead, Mr. Livingston.
Mr. Brown, I don't have the list of who's on the call, so I'm gonna ask you to do that since you communicated.
The folks that we reached out to, not everybody was able to make the call, but I know we do have, I heard Dr. Bell on the call, who's our state epidemiologist. We have, I believe, Dr. Diane Carr on the call.
Correct.
From Midlands Technical College. We also have Mr. Ford from Prisma on the call, and I believe you may have some others joining later. And I believe we have Dr. Jeter from Benedict College on the call as well, Chairman Livingston.
Right. Mm-hmm.
And so we had some other guests, but they had a conflict from University of South Carolina. They may be able to get on later, but they had an initial conflict. And so did Dr. Gerard. He also had an initial conflict. So, but they may be able to join the call later if we're still on.
And the reason for those guests, just for us to get a kind of a brief update in terms of on where they are, so we can, if we need to, we can share that with our constituents and our colleagues as well, in terms of where those important agencies are in relationship to our community. Let me ask Dr. Bell, if she doesn't mind going first, to provide us with a just a kind of brief update in terms of where we are.
Sure. Good afternoon, everybody, and I appreciate the invitation. I'll give you just a brief update. And to remind you, so I'm the state epidemiologist with Deaq, and want to emphasize that we are continuing to respond with our COVID-19 control efforts. I want to report that as of May 11th, we have received 7,792 reports of confirmed COVID-19 cases in South Carolina. In Richland County, we have 1,119 cases and 57 deaths. We are continuing to work on all of our control measures, but one of our main initiatives now, in addition to the ongoing investigative efforts to identify cases and their contacts, is to dramatically expand the availability of testing in communities statewide, and also in a number of areas in the Midlands. We're working with our healthcare partners, with our healthcare systems, with community health centers, those federally qualified healthcare centers, and are making great efforts to assure that providers have personal protective equipment in order to be able to provide testing and to provide care. And as well as the laboratory collection samples that go along with that, to allow us to expand testing and to make that as widely available as possible. And then to follow up on the data, both on the individual level. These are all case reports from people who need our information about the measures that they can take to prevent spread, to protect their families and their communities. But we, of course, are also using the data to help us identify potential gaps where there's a need for additional testing in our communities. We do have a goal to test 2% of our population in South Carolina per month. That 2% of the total population would be about 110,000 people statewide. And I'm, for the purposes of this call, I hadn't intended to break that down for the Midlands, but just so you could have an overview of our statewide goals. And another area that we're focusing on is addressing the health disparities to make sure that we reach the most vulnerable populations who are at highest risk of suffering from complications should they become infected. I always want to remind people that we all generally share the same risk of being exposed if we're not practicing the prevention measures to wear masks, to limit exposure in public, to continue to practice social distancing, to minimize large group gatherings without protection and so forth. So the risk of exposure remains for all of us, but the risk for complications of infection are affecting specific groups more severely. And those are our older individuals, individuals who have chronic underlying health problems, African Americans who have a disproportionate impact with those chronic problems. And so we're working very hard to reach out to those populations to make sure that they are informed and protected. And so we're also moving out to schedule pop-up clinics and mobile testing sites in addition to those fixed clinical ambulatory care settings to provide testing. And so with that, that's just a broad overview. I'm happy to add more or answer any questions.
I could quickly ask if any of my colleagues on the committee have any questions.
Yes, Yvonne McBride.
McBride, go ahead,
Dr.
you recognize.
I was really concerned in terms of the cases in Richland County, based on the newspaper articles. We have the highest number of COVID cases in the state. And I know that the county has not been directly involved in terms of the process used to identify testing and also and getting information out to our communities, which I realize that you all are doing through the television and I guess through the newspapers. My question is, how can the county get more data based on zip codes in Richland County so that as we work with you and others to do planning for addressing the COVID-19 issues?
Yes, of course. So we are making our disease reports by zip code available, and we want to help people interpret that zip code level data. So for example, when I look at that data reported by zip code, and I note that some of the areas where a larger number of cases are reported, for example, 29223 and 29229, the high level of cases are coming from those zip codes. And what we need to examine when we look at that is whether or not that means that there is more disease activity in those particular zip codes, or does that mean that people who live in those zip codes have more access to being tested? And so that's one way to look at the information and interpret it with caution, because if you look at other zip code areas that may not have as many cases, then we've also conducted a gap analysis to evaluate access to care. So we are looking at the distance from the distance of travel from where individual reports have been tested and where their home address may be, how far it takes people to travel, how many testing sites there are. We're also looking at the prevalence of comorbid conditions in different areas. And so it is by doing that, what we call a gap analysis, where we identify gaps and make decisions about where it is most beneficial to provide testing that does not already exist. That's an answer of some of the things that we're looking at, but what the county representatives can do is, so you made, I think you asked a question about the zip code data that is available, and it's on the Deaq website. If you go and search COVID-19, scdeaq.gov/COVID-19 and look at the data portion. And then we're also reporting the available testing sites, and we're working with partners. I know we have some partners even on the line here from Prisma that may be able to address that. We want to encourage our providers to make testing available through their routine primary healthcare settings, in addition to those mobile clinics and pop-up sites. And again, with our federally qualified healthcare centers, we're actually working to do more to make sure that they have access to PPE and testing supplies so that they can provide services in those medical homes.
Okay, thank you. from a policy level, I just would like to see the county working closer with Deaq, given the number of cases we have here in Richland County from a policy level.
Yes, and so if you can, give us more information about what you have in mind from a policy level, I'm probably not answering your question very well. So if you, we're happy to have that support from the county level. If you tell me what you mean by from the policy.
Okay, from a policy level, in terms of the number of cases, and then from a policy level, what types of policies and programs and services can the county put in place to help address the COVID cases, 19 cases, and to help with the leveling off of the cases, given the fact that we do have a large number of cases.
So your question is what the county can do from a policy
To
perspective?
work with you.
Misunderstood. Yeah.
Yeah, in terms of getting information and how we can work together.
The testing piece is important, but from a policy level, it's also emphasizing the recommendations that we have in the community as a whole. So everything that we can do to help businesses follow the recommended guidelines for social distancing, for providing services and serving patrons in a safe environment, making sure that workers, employees, and employers are practicing the protective measures with the use of masks, making hand sanitizer available in businesses. So working with those community leaders, with those business leaders to help with compliance and the prevention of disease spread is a really important policy position that county leaders can help with. It is to get these businesses, as we do the reopenings and provide these services, that as much as possible, we can assure that they are safe environments, that there's not overcrowding. And that to me would be a very important help with preventing disease spread. In addition to detecting it through testing, we have to continue those measures to prevent spread.
Thank you.
Thank you.
Any other questions, Ms. Bell?
Mr. Chair.
Brian, we'll follow up on that with Deaq and Ms. Bell.
Mr. Chair, this is Shakise Newton.
Ms. Newton?
Yes, thank you for joining us, Dr. Bell. I'm glad that you're here. Two quick questions for you. The first question is, I wasn't quick enough writing down some information you gave us previously. And so you had stated the testing goal that you were working towards for the state. Could you repeat that, please?
Yeah, I'm going to look at my notes again. And so I talked about a couple of things. The main thing that is one of our goals is to test 2% of the population of South Carolina for May and June. And so that figure, our goal to test 2% is 110,000 South Carolinians per month. And I think that was the only target that I actually provided here. The other figures that I mentioned were the number of cases reported in Richland County. Since we began the reporting, that was 1,119 cases. And then statewide, we've had 7,792 cases. And I also reported, I may not have mentioned this, the number of deaths in Richland County. We've had 57 deaths in Richland County.
Thank you. Thank you for repeating that. And then the second question that I have, and I might need your help asking this question. One of the metrics that I've been trying to look at is the 14 days of sustained decrease of COVID cases. And so first, as an epidemiologist, I would appreciate it if you clarified that metric for me, because it could be that it's 14 days of the percentage decrease in infection, or there are a lot of ways to parse that number. But if you could explain, what that the best 14-day metric is, and then where we stand in South Carolina, and if you know it, where we are in Richland County from an infection spread rate.
Okay, and there's not an absolute number that we're looking at. That's based on positive cases reported to us. So most of what we're providing that people are focusing on is the total number of positive cases over time, and we're reporting that out by day. And if you look at the shape of that epidemiologic curve, we want to see a sustained downward trend. When we're looking at that epi curve now, we're seeing a kind of a plateau in cases that has that we've been watching for a week or so or more now. But what we'd like to see is a significant downward trend. And to what level, that's unknown, because what we don't know is what level of disease we're ultimately going to be living with for COVID-19. This is a novel infection. We only have the experience of a matter of a few months of this, even internationally. We just identified the first cases in December in China. So it's looking like this is not going to be one of these novel viruses that comes and goes like we previously saw with the severe acute respiratory syndrome and the Middle Eastern respiratory syndrome, which popped up and then went away. The current level of transmission suggests that this is something that we're going to be living with like the flu, the seasonal flu. But whether or not this occurs seasonally or whether we have a low level of transmission on a regular basis in our communities, those things are unknown, and to what level. So what we want to see is a significant downward trend from wherever that plateau is, and that if we have confidence that we are adequately testing the population and that level declines to some significantly lower level and stays there for about 14 days, then that gives us reassurance that we're, number one, adequately testing, and that we're, number two, have adequate control measures in place, because it's not going up, but it will be like other diseases that always occur in the population, whether it's HIV or the flu or vaccine preventable diseases, at some low but endemic level. Does that answer the question?
Yes, that does help. And it sounds like you're saying we're not at that significant downward trend yet. Would you say, and I know that we're watching the data as it comes in on a daily basis, would you say that we're at the beginning of that, or not really? We're just kind of leveling off in this plateau, waiting to see a greater decrease in infection rate?
Yeah, and what we're watching now is that as we've been monitoring that curve at a certain level of testing, and now that we're rapidly increasing testing, we're saying that we are doing everything we can to ramp up testing, to expand testing. So we actually expect that number to go up, because it's our goal to find as many cases. So what we're going to monitor is the proportion of the total tests performed that are positive over time. And if the proportion of positives goes down, but the total volume of tests increases, that's an indicator that we're doing a very effective job at widely testing and finding fewer people in the population who are positive. So the percent positive of the total volume of tests is an important indicator, even if the total number of confirmed cases goes up. And so it gets to be sort of this paradox. Well, we're not at a plateau anymore. We've gone up, but we've gone up with better indicators that the proportion of the positives in the population is a smaller number. And that's the figure that we'll be watching over time. And when we get to that high level of testing, we want to see a drop down from that level. That is a sustained low level without increases, without hotspots, without outbreaks. And then we'll have more confidence. And I understand you asked the question about where we are in Richland County, and I apologize, I don't have that information here specific to regions in the state. I was just able to pull to take a look at I'm monitoring the statewide data more than I am region by region. So I can certainly make that available and let you know and follow up with you about how we're doing in Richland County and the Midlands specifically.
That would be wonderful. And thank you so much for answering my question.
Okay.
Thank you, Mr. Chair.
Thank you. Any more questions, Dr. Bell?
Yes, sir, Mr. Chairman. This is Delia Myers.
Ms. Myers?
Hi, Dr. Bell, and thank you again. Like my colleagues and the staff, I'm grateful that you're here. Just a quick few questions. So you said that the goal, the statewide goal for Deaq is 2% testing for the months of June and July. And that's across the state? Is that correct?
Well, it's a goal to test 2% of the population each month. to reach
Right,
110
across the,
people each month across the state, yes.
okay. And to the extent that in Richland County, we lead the state by magnitudes of somewhere between, 10 and 15 with the number of cases, would you consider that that amount of testing would be sufficient for us as policymakers in Richland County, or should we not be supplementing that testing somehow, given the large volume of cases that we've seen?
Well, and one thing I forgot to point out, I do want you to remember that the total number of cases versus rates per population, one of the reasons that you're higher as compared to the rest of the state is because it's, one of the biggest metropolitan areas in the state. So you also have to look at the cases per 100,000 population, which gives you a better comparison with other communities. So one of the reasons why Richland is really high is because of the population density. But, and another reason you're high is because there are far more physicians and hospitals in our metropolitan areas than in the rural areas. So the accessibility to testing exists. You're already testing more people because of the healthcare providers in the Midlands and the Charleston area, Greenville, Spartanburg, as compared to more rural areas where there are issues with access to being tested. So the fact that there are so many more cases in Richland may be in part a function of the fact that good testing has been going on here. But we do need to look at the percent positive in the Midlands, that same indicator. Are we finding only the sickest people? Or are we finding a broader range? Are we adequately sampling people who are less sick? In fact, even people who are asymptomatic. And when we look at that, we can better answer, is testing sufficient in the Midlands? Going back to those some of the things that I mentioned before, how far do people have to travel in the Midlands to be tested? We know that there are zip codes right adjacent to each other where there are marked differences in access to care. If we looked at 29203 versus 29206, there's a big difference in access to care, socioeconomic status, and things like that between those zip codes. And so those are all the things that we're looking at when we make recommendations for where testing should be performed in response to our gap analyses.
Thank you, and I definitely appreciate that you're going to have to take a much more high-level look at it than we do as policymakers for Richland County. And so maybe I should ask my question in a better way. To knit together what Ms. McBride asked a moment ago with what I'm trying to ask, if we're bringing 100% of the people back to work, should our goal be testing a larger percentage than 2%? And that's not a Deaq goal, that's a Richland County goal. And I'm asking for some guidance on where we should be setting a policy goal for testing. And that would be separate and apart, of course, from what Deaq is doing. But given our numbers, and if you compare them even to Charleston and Greenville, we're still far outstripping them. And I understand that the geography is different and, we have people packed together in different ways. But given that we have to combat the fear as well as the reality, do we need to look, as Ms. McBride suggested, from a policy level at ways to get more than the 2% per month tested so that we can get people back into the stream of commerce as it is without the fear factor? Would that be something that you'd consider that policymakers need to be analyzing?
You do need to be analyzing how many people we should test. I'm not necessarily recommending the 2% population. One of the reasons that measure was chosen is because that's being reported for all states. And so it's a basis of comparison for us with other states. Whether we test 2% of the population is not the best way to assess whether or not we're reaching the right people, because you can stand up a testing event and reach some number, and we don't want to pat ourselves on the back for having reached some raw number unless we understand that we have actually provided the services where they were needed. And so again, I have to say that 2% is not a magic number, but so I'm understanding your question is, how are we going to get people back to work? How are we going to reduce fear? And testing is not the measure by which we can assure any safety. This question has been asked many times. Shouldn't we be testing all of our workers to return to work? We really want to focus on testing people first who are sick and their contacts, and testing in congregate settings. If we begin just testing everybody in the population, especially for the purposes of return to work, you have to ask yourself, well, what happens if they then become exposed and they're sick? How often are you going to retest people who are not sick? It's not a, if they test negative once, we don't want people to get a false sense of security that, well, I tested negative, I don't need to practice personal protective measures or anything of the kind. It just means that you were negative at a point in time. So I know that you're asking for the best answer for what do you need to do from a policy perspective for testing. And I would say again that we need to assess the gaps in our communities to make sure that we're doing an adequate sampling across geographic areas, across racial and ethnic groups, across socioeconomic status, access to care. So I can't give you a magic number for that. It is an ongoing assessment of the gaps where care is needed and who we're missing.
Thank you.
But you would say it has to be a part of the mix. I don't view it as a panacea either. I understand what you're saying. I hear clearly what you're saying, and you wouldn't want anybody to take a test, a negative COVID-19 test, as some sort of badge of honor and then go out into the world and not exercise caution. I get that. I guess what I'm asking is, do we have a different standard that we need to be looking at than, for example, York County that hasn't experienced the level of virus infection? And so I just want to be sure that we're doing what we need to be doing to supplement and support what Deaq is doing, rather than setting that as, I understand that that's the national standard, and I understand that there are discussions on both sides of that number as to whether it's adequate, inadequate, all of that. But from a Richland County standpoint, my goal is to sort of help move the needle in a positive direction. So I'm just trying to find out, I know 100% is too much, but is there a continuum on which you think that there is something more than 2% that a county like ours that has experienced the level of impact that we have from COVID-19 might want to look at more closely?
And I don't have a number to give you. I don't think that there is anything different that you need to do from Richland County as compared to York or another county strategically, because the strategy is to assure that adequate testing sites are available to provide those who need the services testing. We want to focus on those who are sick, who are outside of a hospital setting, because we first had to focus on the hospital setting. So in the community now, I cannot say that in Richland County, I think that you should do these things that would be different from York or Charleston or any other county. The strategy and the approach that we have is really the same in every community. The challenge is finding out where to put the services. So the magic number might be different from one community to the next, depending on where they've come in terms of testing that's already been performed. What is the level of community transmission going on, so that the number of people who are sick in that community? If we have higher rates of disease, then that means we're going to be testing more sick people in one community to the next. I don't think there's anything different that I would recommend from one community to the next. And again, I want to go back to not so much the testing. I don't want people to lose sight of the prevention measures. I'm rather alarmed by the fact that as I try and restrict my activities in public, when I do go out, I would say that 10% of the people in businesses and stores, when I have been out this past weekend, had on masks. And so I think that message is being missed, excuse me. And so from a policy perspective, reinforcing what we can do to prevent disease is equally important, perhaps, as finding disease that's already present. Our goal is to stop.
That's my second question. I just kind of wanted to get a handle on the 2%. My second question has to do exactly with nose and mouth coverings, and if from a policy perspective, you view it as the responsibility of a policymaker to be, as you said earlier, urging and in some ways using coercive methods to get people to maintain those nose and mouth coverings while out in public where, you know, there may not be a 6-foot distance, but to encourage both nose and mouth coverings, social distancing or physical distancing. Is that
Right.
correct?
That's right, because it's not one or the other. We don't want people to think if I have on a mask, then I can go in a large social group. It has to be both. It has to be the social distancing because the masks are not 100% effective. And
Right.
especially, you know, many of us are having to use, they're not the medical equipment designed to prevent a certain level of filtering. So it has to be both the social distancing and the use of the masks and the personal hygiene and limiting large groups. It's all of those things.
And so this is my last question, Mr. Chairman, from a policy perspective, with regard to bringing people back into the workplace, would you suggest some form of staggered working? What would you suggest for a building like our building that houses large numbers of people and welcomes in the public on a daily basis? Would you suggest staggered working hours and continued working from home for those people who could on different days of the week? What are your suggestions insofar as reintroducing people into the workplace, even observing all of the good guidance you're giving with regard to physical distancing, nose and mouth coverings, washing your hands, using hand sanitizer, all of those things? What would you suggest would be something we need to be thinking through with regard to bringing people back into the building and welcoming the public?
What building are you referring to when you say
Well,
building?
2020 Hampton Street is our main building, but we have, you know, buildings all over. So just the county's buildings, the
Oh, the county
courthouse,
administration building, I
you know.
got you. Well, so for the Richland County Administrative Building specifically, because this guidance, it really does have to be site specific and it has to be specific to the type of service or the type of business it is, the type of patrons. But for the Richland County administrative buildings, some suggestions that we've given to businesses are controlling ingress and egress so that you don't have people walking in and out of the same door. This is an entrance only door. This is an exit only door. You can control attempts to control the number of people who are coming in at one time. That has to be monitored somewhat. And then when you have people waiting in line to get certain county services, making sure that they're waiting in a safe area, that they're spaced away from other individuals, that you may do things like setting up appointments so that you don't have a large number of people in one space at one time, that when possible, that there is signage that recommends that people use masks, and when possible, if they don't have masks available, that those can be provided by the businesses, that hand sanitizing stations are available when people can't immediately get to a sink. So the general business practices, we've provided that guidance, and so adopting that to the type of services, because I know that we're co-located there with the Richland County Health Department. When I'm thinking of the immunization clinic there, and you know how that waiting room is set up, the waiting for services, for clinical services, and the administrative services, businesses should find a way to space people out, to limit the contact time that they're in close proximity. For those individuals that are providing the services, that there are shields, the kind of plexiglass screens to protect workers so that they don't have to wear a mask for an 8-hour day. That can get to be very problematic. Those are just some of the measures, but I would direct all businesses and all service organizations to guidance that is specific to a variety of different settings. We're getting the same question from businesses that may be doing from everything from manufacturing to the restaurants, and it has to be very site specific.
Thank you.
Thank you.
Any other questions? Thank you very, very much, Dr. Bell. We're so glad to have you.
Mr. Chair,
Yes,
may I ask a question?
yes, please. Go ahead. Mr.
So
Ramsey.
I really appreciate Dr. Bell sharing with us, you know, what testing will look like and trending of testing and cases and all of that. So my question is regarding so let's say we have a really nice steady downward curve of new cases. We're testing at an appropriate level. And then what if we see kind of a new spike or recurrence? I keep hearing about, okay, well, we may have kind of an open up and then close, like an opening and closing kind of situation. Could you speak a little bit to what that might look like, and if you have any guidance on, maybe there's kind of an anomaly of a little spike in cases, or how do we know when we really need to be concerned about a strong resurgence again?
Yes,
Is that question clear?
the question is clear. I hope I can give a clear answer, a better job than I've been doing. But so it's our responsibility in public health to investigate individual cases and to also investigate clusters of cases to see if we can identify connections. If there are social networks, if there are common settings that they have shared a potential exposure, so that we can attempt to take measures to prevent ongoing spread associated with a common exposure. And so some of the things to watch for, though, we may see some big jumps in testing in a community where the community may just see the jump in the number, but they may not be aware that, well, actually, we tested a nursing home that had 300 beds, and we tested all of the residents and all the employees, and 50% of the people in that facility were positive. So it creates a big jump in the total number of cases. But we are aware that that happened in a congregate setting, and we can address that, even though those findings are very unfortunate and very concerning, but we can address those findings within that congregate setting, and it doesn't necessarily mean that the community as a whole is at risk by a jump in numbers like that. Other ways that might happen would be, we know that there's testing in correctional facilities, and there can be high numbers of positives. And so those are kinds of things that make the numbers jump up artificially. But what we need to be really on top of is if we see community connections, and if we interview cases and they will say, yes, we all attended some particular function, then we would do an intensive contact investigation to identify who are the people that participated in that activity, to let them know that you are potential contacts having been in that place, and you need to take special measures to go into quarantine, to monitor for symptoms, seek testing. And so there are differences in what the data tells us depending on where the test results were performed. If we're doing a big community testing event and we identify a lot of positives, well, those positives wouldn't be associated with that testing event. Positives are reported by their address, but it is through interviewing them and finding out, well, where have you been? Who have you been in contact with, to help us address potential outbreaks and red flags. And we learn from those, and then we can inform the community saying that, we identified a problem from this type of activity, and for this reason, we recommend against this type of activity. Is that helpful?
Yes, that's very helpful. So, what you're describing is contact tracing. And I guess my follow-up question would be, are we taking steps now, and how can Richland County be a positive part of the process of ensuring that we have enough people to do contact tracing, and that we can do that timely before a small cluster might then start to spread?
Yeah. So contact tracers, we're getting a very positive response from community volunteers, from healthcare providers, from public health professionals who have retired from public health practice, and other students from higher ed. We have a large number of people who have volunteered to assist with contact tracing. So we're working now to get them trained up with some just-in-time training, some already prepared learning initiatives that explain for people who haven't done this work before, what contact tracing is, what the interview process is. It's not that difficult for people who are accustomed to working with people. In fact, we're recruiting teachers, community leaders, anybody who's accustomed to working as a leader in a community, in fact, can become a contact tracer pretty quickly. It is connecting the data to get access to who the positives are so that they can help with that. So I feel like in Richland County and in a number of communities, we're getting a good number of volunteers. The beauty of the system is that much of the contact tracing can be done by phone. So wherever you are in the state, you can reach out to the contacts of individuals. So it doesn't have to be, Midland specific. So I think that we're making great progress with identifying contact tracers to help with this effort.
Thank you.
Thank you. Any other questions, Dr. Bell?
Yeah, Mr. Livingston.
Ms. McBride?
Dr. Bell, we've taken up so much of your time and we truly appreciate you coming to talk with us. The last question maybe can be answered later, because I know you talked about when we get ready to bring employees back to work. And I know that there has been national guidelines on the leveling off of the number of cases. So I'm not sure yet. And so maybe this is something that you could talk with the administrator about later. How do we determine at what point it's safe to bring employees back to work? And I know this might be more than you can answer right now. So if we could talk later or have someone, you can guide us in the best way to do this or refer us to the most appropriate persons.
Yeah. And I will say this now, because there's not a number. There's not a number. What we want to create is a safe environment. So regardless of disease transmission in the community, because we're continuing to see relatively high levels of disease transmission, but we are bringing people back to work. So the focus has to be on the prevention measures, not the disease activity in the community. Since we're doing the relaxing and restrictions and the reopenings, we really need to focus on the safe workplaces regardless of disease activity in the community. Yes, we do want to see a significant downward trend and we want to see that persist for at least 14 days. But in the meantime, people are coming back to work. And while they're doing that, while there is a high level of disease activity, we want to make sure that they recognize the importance of wearing masks, that there may be people in the community who believe I don't need a mask because I'm not in one of the risk groups that was listed. I hope that that's not creating confusion for people in the public, that if you're not older, if you don't have a chronic medical problem, or any of those things that we say put people at higher risk for complications, we want people to understand though, you can still become infected and you can still spread that infection to someone in your household, your loved ones, your community members. So it's still important for you to use the protective measures and be community minded, even if you don't believe you personally are at risk. If people are taking that risk for themselves, they're not only doing that risk for themselves, it's a risk for the community. And so to the extent that we can be successful in getting everybody to be community minded, the more rapidly we will get to that downward trend. And so as people continue to participate in behaviors that aren't recommended, and I mean, these are optional activities that, we see these social gatherings, they're not essential activities. They're just people, on the streets in 5 Points, shoulder to shoulder. It was on the front page of the paper, students out there, not a one of them had a mask on. And that concerns me deeply. There are things that we can do about that to prevent disease spread. And as long as we continue to see those types of behaviors, we're going to continue to see high levels of disease activity. And so it is the prevention behaviors that we really need to continue to stress, regardless of disease activity in the community.
Thank you.
Thank you very much. Any other questions? If not, let me is Dr. Carr still online from Middle Technical College?
Yes, I'm here.
I'm actually go ahead and give us an update in terms of Midlands Tech.
Okay, thank you for letting Midlands Technical College be part of this process. I do appreciate it. We have just ended our spring semester. We went entirely online, either synchronous or asynchronous, right after spring break. We continue to have almost all of our employees working from home, with isolated people coming in and with our custodial workers coming through and cleaning regularly. We are putting almost all of our summer classes online, and we hope to be able to bring back students to campus by June 26th, which is our second session of summer, only for those who need to be on campus because they use heavy equipment or otherwise have to be on site. So the welders and the electricians and some of those students who need to have that hands-on component that we have not been able to figure out how to do online. We are still waiting for some guidance from our clinical partners for our healthcare students, doing as much online as we can with them and as much by simulation as we can, but there are some clinical components that they will need to do. Some of that may have to get pushed into the fall semester until those healthcare facilities are ready to have students back. For fall, we are hoping to have some students back on campus, but also to offer a lot of online opportunities for students and for faculty who should not be back in a group setting or don't feel safe in a group setting, and to keep the sizes of groups down to a safe level. So limiting the number of students in a classroom or putting classes in auditoriums so that there's more space between classes. Trying to manage our schedule so that we just overall, we have some classes meeting online while others are meeting in class, so we don't have large numbers of students in our buildings at the same time. Having our custodial workers know what the schedule is and where students are, and leaving enough time in between where students are meeting that we can come through and do some cleaning in between students. So we're moving very carefully and trying to adjust to information as we know it in order to keep our students and our faculty and staff as safe as possible.
Thank you. Any questions for Dr. Carr?
Just a quick question, Mr. Chair.
Ms. Myers?
And this may not be a question that you can answer. Have you all done any in-depth analysis of what the budgetary difference has been in having everyone online and having folks in the building, or is that something that obviously may be well out of your wheelhouse?
We had some initial costs in moving online. We had to provide equipment to some of our instructors. We bought some cameras so that instructors could videotape themselves doing demonstrations that could then be online. So we had some initial outlay for budgets. We're still, of course, paying our faculty to teach. I don't think we've seen any decrease in what we have been spending as far as having them online, because we bought Zoom licenses and we had some costs like that, but I'm not sure I'm answering your question.
Well, it may well be that it's poorly directed to you, so I can hold it. Thank you.
Dr. Carr, what's happening in terms of graduation for students?
I'm happy to say that with the exception of 2 programs, all of our students who were supposed to graduate at the end of the spring semester were able to complete their what they needed to do for graduation, and they have officially graduated. We are continuing to work with some students who needed to be on campus. That's going to take us a little longer. We're set up for summer so that those who are supposed to graduate by the end of summer will actually complete those requirements by the end of summer. We have rescheduled our graduation for, I think it's December 9th, in hopes that we can have a face-to-face graduation at that time, and will include students from the summer and the fall in that graduation as well.
Any other questions of Dr. Carr? If not, Dr. Carr, I certainly want to thank you so very, very much for sharing that information with us.
Thank you for letting me do that.
Did Mr. Ford sit on the line? Mr. Ford from Prisma?
Yeah, I'm here.
Mr. Ford, just give us a brief update in terms of what's happening with Prisma.
All right, thank you, Mr. Chairman, and members of the County Council and other distinguished guests as well. I don't know if Dr. Gerard is on, so if there are any clinical questions, they would have to go to one of our physician leaders. But just overall, Prisma Health obviously is engaged in the middle of the COVID crisis that is going on. We are standing up. We have stood up a few testing sites across our footprint, from Richland County to Sumter County and in Greenville. Most of you are probably aware that we did 3 different testing sites, May 6th at Hopkins Park, May 8th, at McCoy's Ferry at the Richland County Rec Community Center, and then this past Saturday at Lower Richland High School. I don't have the numbers from Hopkins, but the numbers from Eastover in front of me right now, 171 tests were administered, and at Lower Richland was 448 administered tests. We have been working with the local school districts, providing our clinical staff has provided answers and to their questions about graduations, most of the school districts have been challenged with determining if they want to do a virtual or in-person graduation. And so they're deciding through that what they're going to do. Most of the students, obviously, high school students, wanted an in-person graduation. And so we answered questions to that to determine if they were to do an in-person graduation, what our recommendations. We continue to work with the homeless shelters. As you know, having men and women who are in transition, who are moving about all day long throughout our county could be problematic. Early in this process, we worked with the city to get them to open back up, for instance, Finley Park restrooms, because even though there was a curfew, not all of the men and women who were in shelter were going into the shelters. And so there needed to be a restroom facility, doing things like that. Just heard this week that we're continuing to work. Dr. Bell lifted up and discussed working with the prison population. There has been a high number of prisoners, prison people, I don't like using that word, that were positive. I know Kirkland is one of the facilities that we heard from. A week or 2 ago, Mr. Brown called us and we sent out a team to test an individual, a juvenile at Alvin Glenn. And then just finally, and there are many other things I can share, finally, we're in the process of standing up childcare, an additional childcare facility in anticipation that everything's going to open back up. We working with Richland 1 and Carver Elementary, and with the YMCA, who would staff that for us. We would open that up only for Prisma team members, Columbia Free Med, the dental clinic at there at Hampton Street, along with the first responders, fire department, and local law enforcement as well. So we're in the process of developing that MOA so that we could have that ready if and when government totally opens up, back up, and therefore there will be a need for what we'll call emergency childcare. So just some of the things that are going on, many others. That's a quick report. Mr. Chairman, I'd be happy to answer any questions.
Do any of my colleagues have any questions?
Yes, Yvonne McBride.
McBride, go ahead, please.
Mr. Ford, how are you doing?
Well, and you?
Great. 29223 is one of the areas that has been indicated to have the highest number, one of the highest numbers, the numbers of COVID-19 cases. Has there been any, I know that there was testing in 29203. What are the plans for 29223?
So I think the goal is to, I think Dr. Bell did an excellent job of really kind of determining where testing sites could be. And what the Prisma Health staff is in the process of analyzing what we call hotspots and where they're higher risk for, so that we can provide testing. So an additional plan is soon to come out. Dr. Sasser and his team, Dr. Shelton, who are lead on this, are in the process of determining where the next sites will be. As you can imagine, we've received calls to have sites at many different locations. And so all of that's being examined, and we'll put a list out in the next few days if possible. But yeah, 29223 is looked at. They're not that it has to be Prisma, but other entities are providing testing in some of these specific areas. I do know that there was a hospital, I think, from the Low Country that came to town and did some testing. Eau Claire Health Center, Doctors Care, and then some physicians as well. So a number of entities are providing testing, and we're going to continue to evaluate that and determine where best to provide testing at testing sites as well.
Okay.
More information to come, and you'll know about it.
Okay, I appreciate the work that
you.
Prisma is doing, and also appreciate the involvement in the future involvement of the county with it. So thank you so much.
Absolutely, without a doubt. And Mr. Brown, I will tell you, Mr. Brown has been in constant contact with us, and he has kept us informed, kept me informed, and and we've tried to be responsive to what he has requested. So yeah, we're definitely talking to the county on an ongoing basis, and I know a number of you as well are talking to senior leadership on an ongoing basis. So many of you are informed about what Prisma is doing.
Mr. Chair.
If not, Mr. Ford, we appreciate you taking time to provide that information to us.
No problem,
Mr. Chair.
I'm sorry, one of my colleagues here.
Yes, this is Shakise Newton. Thank you
so
so much, Miss. I do. Thank you so much, Mr. Ford, for joining us. I guess as a follow-up question to the questions that you answered for Ms. McBride, I think I heard you say that you're going to be looking at where the hotspots are and determining where you're going to be placing additional testing locations. My question to you is, to the extent that you know, do you have an idea in mind in terms of the frequency with which you are planning on offering these pop-up testing sites, or is that purely in response to the data that you're seeing in terms of where the hotspots are? And then my second question, the testing is very, very important. We've seen at different parts of this epidemic, different amounts of turnaround in terms of when people are getting those results back. So for example, when you look at the locations that you were able to have testing in this week or for future testing, what is your anticipated turnaround in terms of when people might get the results of their tests?
So two good questions. So the results, I wish Dr. Gerard were on. So it depends on, depends on the labs that are being used. It would determine the turnaround time. So if I give you a specific answer, I might not be totally accurate. So it just depends.
Sure.
But we do know that in some cases it's going to take days, but obviously as soon as possible, because the sooner people know, obviously the better. But we do know for a fact that the average is a couple of days. And the hotspots, the clinical staff is determining where those hotspots are, and they're trying to stand up these testing sites. We believe that we want to try to spread it out across the county. And I think Dr. Bell did a great job earlier talking about access to care, trying to determine, where there's public transportation or transportation challenges, I should say, and putting it in place where we can maximize the opportunity to provide testing. I think, as an example, the 448, almost 500 tests in Lower Richland on Saturday was pretty phenomenal. And trying to put it in a place where obviously there's a need and the ability to administer that without any complications in terms of traffic flow, et cetera. Those dates and locations will be put out real soon, and we'll make sure that Mr. Brown has them and that we can share them with all the county council members as well.
Thank you so much. Thank you, Mr. Chair.
Thank you. Any other questions? If not, Mr. Jeter, Dr. Jeter, are you still on the line?
Yes, I'm here. Can you hear me?
Yes, this is Dr. Jeter from Benedict College. Dr. Jeter, we want to share some comments from Benedict College.
Okay, well, thanks for having us on. Glad to be a part of the meeting. Well, I guess Benedict is just like most institutions in the country. We're caught behind the 8 ball of this pandemic thing, but we're doing our best. Benedict actually has a emergency management and COVID-19 task force that's been pretty much on the ground running ever since this thing happened. And they've been pretty much in contact with from the governor's office on down, trying to adhere and follow with the rules and policies as we can. We did, after, just as an update, we too went to virtual, 100% virtual courses after spring break. All of our courses were offered to students around the country. Many students, we actually sent laptops to students and made arrangements for them to have internet, things like that in real time. We did have completed, we've gotten through, we're on the downside now. We had graduation of those who graduated in May. Degrees were conferred this past Saturday on the 9th, and we're very glad about that. We're planning to have 100% online summer school starting in June, summer session there. In addition, we're going to offer a online summer virtual cyber camp. We'll offer that this summer as well. The plan is to have graduation at sometime in the fall. That date is still sort of up in the air as far as based on how things are going to go. Basically, as I said, the committee is pretty much working in real time with all the major stakeholders. So a lot of this stuff is, some of us is a moving ball because we're still student focused and student centered. We have sort of a plan A, plan B for the fall. If everything clears up, then we will have campus courses. If not, then we'll do virtual, but that still hasn't been 100% decided yet. But for the most part, I think that, we've been working well with students and faculty members, adjusting to the new normal, so to speak. But that's sort of where we are right now, and we're sort of grinding and trying to stay strong and, support students and support families and faculty and friends and families as best we can. Okay.
Thank you very much. Any of my colleagues have any questions of Dr. Jeter?
Mr. Chair, I also wanted to make you aware that Dr. Gerard is on the line from Prisma Health.
Thank you. Any other questions from Mr. Jeter? If not, Gerard, would you like to add or compliment any of the things that Mr. Ford said?
I think I might have tagged right on there at the end. If anybody wants to ask a quick repeat, I can give an answer.
Dr. Gerard, one of the questions that was asked was, what is the turnaround time on the testing? And then what are the particular hotspots that we're looking at to stand up testing sites?
The turnaround on the testing right now is, look at the number, the volume we're doing right now. If they're going to Deaq, they're taking 2 to 3 days, so we're getting those back. It depends. Some tests are actually going back to the hospital and can be, run the same day, depending on, what site we're using, what we're screening for, whether we're just doing a generalized population screening, whether it's screening at a nursing home, at a homeless shelter, kind of prison type area, those could be done much more rapidly. And there was a strategic task force that met this afternoon that again is looking at the critical population to get that 2% number and making sure that we're covering all the areas and all the places that need to have testing. And again, with our mobile integrated health team, we're offering ourselves out there for people that actually can't get to and access testing centers. We're going to them for those that don't have the option of walking or driving to a test center.
You know what hotspots we may be looking at, Dr. Gerard? Someone asked specifically about 29223.
Yeah, I know right now we've focused on, the Eau Claire area, Hopkins, Eastover right now. And I wasn't part of the afternoon. There was a 2-hour call this afternoon on further strategy for doing the antigen testing. And of course, the next strategy, I want to do the serological testing to see who is positive and who's had it that doesn't know about it and may or may not have immunity, depending on what the science plays out.
Any questions from my colleagues?
This is Councilwoman McBride. I think that Dr. Gerard answered my question, had answered the question that I was thinking about in terms of the antibody testing. Are plans underway? Is that what you were saying, or what's the status?
Yeah, right now that's, the market has been flooded, with those tests that are kind of popping up. There's about 70 of them, and really 5 of them are approved. And there's really 3 phases of it. You find out if you have the antibody and you find out if you're positive. Then obviously some of the ways we're treating people is treating people with the serum of people that have the antibody. So then there's actually testing of antibody levels and antibody level reactivity if you want to be a candidate. But the biggest thing is for us to be, from a public health standpoint, is going to be getting out there and going to some of the higher risk places and testing people and see how many people had it and didn't even know it. So we have a real idea of the true numerator and denominator. You keep testing, you're going to keep getting positives, but you got to actually get out there. Well, who really had it, who didn't know about it. And then you really get down to, again, what is the incidence of the disease and what is the mortality rate? And until we get into antibody testing, we won't have those answers. And we are coming up with the serology plan that will finish up and wrap up soon after we make sure that we have covered the sufficient population in the state for the antigen testing and see who's currently infective and make sure we do the appropriate contact tracing and those issues. So these will run in tandem, and then we'll have a better picture. And we're learning more every day. Every time I talk, I actually date time it to the minute, hour, second, because what I tell you right now might not be true in 30 minutes.
Thank you.
Thank you. Any further questions for Dr. Gerard? If not, again, thank you so very much. And let me thank all our presenters for taking time out of their busy schedules to join us and provide us with that very valuable information that we can use to better serve our citizens in Richland County. If there are no other questions referring to our speakers, we'll move forward with the agenda. Again, to those speakers, thank you so very much. Let me
thank you.
Thank you. Let me entertain a motion for the adoption of the agenda.
Mr. Chair.
Ms. Needy, you recognize.
Thank you, Mr. Chair. Mr. Chair, I move that we amend the agenda to add an update on the COVID relief grants. And I will defer to the body's pleasure in terms of where that item can go. And then, given how vast the topic of coronavirus and COVID is, I didn't know if it would be prudent to add an other items category as well for topics that may come up that we don't have a home for on our agenda.
Okay. I'll suggest, since we want to get through some of the things on today's agenda, and I spoke briefly about the update with Mr. Brown, and he didn't think it would take he wasn't sure how much time it would take. Can we put that near the end after we get through some of the materials that we're covering now? if there's
That
no
would
objection.
be, that would be fine with me. I don't know if there's a second to my motion.
I second it.
Okay, we'll do an 7B, and that'd be an update. And then we'll do a 7. Well, and then we'll do a 7C. We just call that other items.
Thank you, Mr. Chair.
Anything else after the adoption of the agenda is moving and second for adoption as amended with those 2 additional items. If there's no further discussion, Ms. Roberts, can you call the roll for the adoption of the agenda?
McBride,
Yes.
Livingston,
Yes.
Myers,
Yes.
Newton.
Yes.
It passes.
Thank you very much. Next item is approval of the minutes from our April 16th meeting. Chair, entertain a motion.
Move to approve.
Motion for approval. Is there a second?
Second.
Yes, sir. I second the motion.
It's moving properly second. Really reference the minutes. If not, I'll ask Ms. Roberts to call the roll for adoption of the minutes.
McBride,
Yes.
Livingston,
Yes.
Teratio. I'm sorry, Myers,
Yes.
Newton.
Yes.
It passes.
Thank you. That brings us to our agenda item. Let me start off by saying answer at least one of the questions that were asked, which is a very good question. I think Mr. Myers might have asked that question about backup material. Ms. Myers, one of the reasons is the main reason for this particular meeting, the reason why we was trying to have it last week rather quickly, is because the purpose of the meeting was primarily to talk about these topics, develop some ideas and guidelines from the committee, and then come back to the committee with some very specific details and backup and so forth about. So it's a way to come to the committee with solutions to get for these particular issues. So that's kind of one of the rationale why you don't have the backup information.
Thank you.
Because a lot of the things you were talking about, particularly a lot of the information you got from Dr. Bell, the administrator and staff have been particularly in regular meetings, particularly with the regional director of Deaq, getting a lot of that kind of information and so forth. So a lot of that would be involved in the discussion from the administrator based on the feedback they've gotten from Deaq and other sources too. So I'm going to, at this point, I'm going to ask Mr. Brown to go ahead on and walk us through those particular items 4, 5, 6, and 7, and then we'll move on into the update and the other items. Mr. Brown?
Yes, sir, Mr. Chair and members of the committee and council. So starting with item 4, the idea behind the criteria and standards for opening, I put down a few items under there, sub items, to give the committee an opportunity to weigh in on your thoughts for what you believe to be the criteria that you would want to see some type of opening under. So we've heard Dr. Bell. You may have seen the White House guidance on opening. There are different people who have different thoughts about what standards they want to see that will allow them to decide how they want to open and when they want to open. So the question from me to you is, what are your standards? So I put under there just some ideas to get the conversation going so that we can understand and draw from you your input. So one of the things that you may have even heard Dr. Bell talk about was some level of data. So as you think about how you might want to open and when you might want to open, what type of data do you believe that you want to utilize, if any at all, in making your determinations as to when and how you might open? So again, where might that data come from? What type of data would that be in terms of type? Whether there's, as Dr. Bell described, some level of percentage increase or decrease, some numbers that you're looking at. So to get the conversation started, I want to give you some ideas, but really we want to draw from you as the policymakers, what decisions would, in your mind, be the keys to deciding from a standard standpoint, how the county would would open, whether that's, again, in a phased approach or an all or nothing approach. And again, whether or not they would involve some level of data. So I'll stop there on this particular item to get the discussion going and get input from the body.
Okay, thank you very much. Anyone would like to be recognized to respond to Ms. Brown's comment? Ms. McBride, is your hand still up? Is that from another time?
No, but I'll go on and respond. That's from another time. You know, I find this sort of somewhat confusing or conflicting with how I see the process working. I think it should be based on scientific research data based on COVID-19. I would like to have the best practices, the best guidance presented to me, and then look at it based on that and make a determination. But for me, a non-scientist, to come up with some criteria is not very prudent, I don't think. And I'm not comfortable with coming up with suggestions without having some scientific information provided or public health information.
Mr. Livingston?
Yes.
I would like to agree wholeheartedly with Ms. McBride, and I'd like to ask the staff if we've asked for the CDC guidance. I've been reading that, you know, the White House got this guidance that went from soup to nuts, literally from daycares to hair salons to office buildings to everything, but decided that it was, you know, for political reasons, they held it. Well, I also read this morning that the CDC has said that it will provide individual guidance to municipalities and states who request it. So maybe what we need to be doing is asking them for guidance. That would be my first request. And they have a hotline that's available for municipalities like us to seek guidance. And that, I think, in harmony with Ms. McBride, that would give me a lot more comfort when looking at things to, you know, suggest. And the second thing I would say is that I'd actually, given how political and politicized the whole response to COVID-19 has become, even down to whether or not we require people to wear nose and mouth protections or masks, and somehow that's a civil liberties violation, I'd actually like this committee to consider whether or not we think it would be helpful to have just a neutral person who is a medical professional to help Richland County walk through these questions. Because I, like Ms. McBride, think that it is very dangerous given the deadliness of this disease. And I heard the information from Dr. Bell, and I have great respect for her. But looking at Richland County's numbers, I just am not comfortable saying that we have the expertise to say that, you know, 2% is the right number, whatever percent is the right number. I'd like some expert who's looking uniquely at Richland County to be providing us guidance and helping the staff through this on a daily basis. Maybe we need a temporary, you know, Richland County epidemiologist or somebody, some group who's hiring themselves out. I don't know, but I agree with Ms. McBride. So I would make those two suggestions.
Mr. Chair.
And Ms. McBride, you recognize again?
Yes, I would like to follow up with Ms. Myers in terms of getting some experts in to help us. I too think this is very political and we need a neutral person. I'm not that comfortable with some of the responses that we received. So I fully support Ms. Myers' recommendation to get experts' opinions, a neutral person that's not actually tied into the government here, which makes it sort of impossible to give clear answers in some cases.
Okay.
Mr. Chair.
And Ms. Newton.
Thank you. And I think that I will try not to repeat what Ms. Myers and Ms. McBride have already said, because I am in agreement with those comments, a lot of those comments. I guess from my perspective, echoing back to what they said, the thing that I can say for sure, and everyone has already said that we agree on this, is that we do want a scientific standard. So to Mr. Brown's question, what kind of standard do we want? Yes, we would like to use a scientific standard moving forward so that we have some objective way, whether we're working with an outside epidemiologist or whomever, which I think is a good potential path forward. We know that we want to base it on the science, but I can't say which science that should be. That said, I am under the impression that this is something that staff has also been investigating for a while. And so while you're coming to us for our feedback, and we're happy to say what we know and acknowledge the things that we don't know, it would be helpful for me if maybe you gave a thumbnail sketch of the different guidance that you have been looking at, and perhaps if there was any guidance, whether it was from the CDC or other bodies, that seemed particularly appropriate for the context of Richland County, and the outlines of what that guidance was, that would be helpful, providing that as a starting point that helps us give you additional information as opposed to us pulling out particular scientific standards. Thank you, Mr. Chair.
Thank you. Any other comments? And I think this is good, because I think this is getting at, I guess when you look at number 4 there, the top part of it said criteria and standards. When you say use CDC guidelines, then you're talking about a standard. So I think we are somehow indirectly answering the question, which is good. Any other things, Mr. Brown, you want to respond to anything or anything else as it relates to item 4?
So just related to item 4, yes, members of the body, we have members of the team who have looked at various standards that are out there, certainly looked at the federal guidelines, as the CDC is certainly one of those bodies that we've referred to many times. So the CDC, the World Health Organization, and then locally, Deaq has also weighed in, and the state has also issued its plan, and many of those same information is communicated, talks about some level of reduction, but it does not necessarily give a must or a shall. That's kind of why I was asking, from the standpoint of, how this body might see its decision. So certainly we can reach out to the federal government and determine what resources might be available from a non-South Carolina standpoint, in terms of having someone who may be tied to a state decision involved in the process to help guide this body with additional information. But pretty much everything that we've looked at, folks are making decisions and are reopening on some phased approach. And so that's, again, why I was coming to this body, just asking, again, what are your thoughts about, as a body, what you want to see? So we certainly have some ideas of a phased approach and some ideas about what data might look like. But again, that's all based on some of the same information that we've been hearing and listening to, as you just heard reported by Dr. Bell. So we'll go back and try to find some other data sources beyond that. But that's all I have on that particular area, Mr. Livingston, as in terms of trying to figure out what criteria, what standards the body wants to make its decisions from.
Okay.
Mr. Livingston?
Ms. Myers, go ahead.
I'd like to specifically ask you guys to ask the CDC about the guidance, not the guidance that it's propounded already, but the guidance that it wanted to put forward, that they've said they will provide on a case-by-case basis, but they have not been allowed to put forward nationally, because there are standards in there that tell us what to do in situations according to what's been reported in the media, even down to should kids go to summer camp. So they have some guidance because, they're the experts, and fortunately they're nonpartisan. So I would just ask that specifically that call be made. Thank you.
Yes, ma'am, will do.
I have a question regarding standards, criteria that relates to opening, questions centered around number 4 there, item 4.
Yes,
Mr.
Mr.
Chairman.
Chair.
Ms. Newton had her hand up before me.
Yeah, I guess Ms. Newton and then Ms. Manning.
Thank you, Mr. Chair and Mr. Manning. Mr. Brown, thank you for the answer to my question. And I understand that you're going to go and pursue the recommendations from the CDC. I guess, again, my question would be, as you have been investigating this and preparing some outlines of plans, has there been a particular set of standards that you have deferred to that has informed your thinking now? And it doesn't have to be where you say it was this specific body standards or that specific body, if it's not that. If you can't recommend it that way, but rather in terms of the thinking that you're seeing, in terms of the best practices that you're likely to recommend for us. I guess I'm just curious to see what those are. For example, you mentioned a phased approach, which makes sense. We wouldn't want to flip a switch and try to go back to business as usual because we can't do that. But I guess while I want you to get that information from the CDC, at the same time, I want to acknowledge the work that you've already done and see if there's other information that you want to share with us that we can be thinking on. Thank you, Mr. Chair.
So to answer your question, Ms. Newton, some of that information is actually listed out as a part of this agenda. So that those are the areas that I thought would help as the staff has worked on what it thought would be a good combination of best practices and what we've seen from other areas across the country, whether they're in the state of South Carolina or other states. So we thought that this information listed here would help guide you all to have a conversation that would help us better determine, again, based on what we've seen, how would we apply that locally to meet Richland County's version of what that looks like versus maybe what it looked like in another county in the state or another county outside of the state. So yes, ma'am, there are some other thoughts we want you to try to address, and it's really kind of set up in this breakdown that you have on the agenda.
Okay, well, I appreciate that. And I guess when we get there, I mean, there are a lot of these items are listed, but there are a lot of questions that are behind each of them. So even if you look at something like a phased-in approach, where we can say, generally speaking, a phased-in approach makes sense, what determinations, for example, has the county made about who they might recommend phasing in following the specific health standards? Because the health standards are going to tell you how, but they're not going to tell you who. And those are recommendations that we would need to get from you. So I was just trying to get a clearer picture of some of those questions. But thank you. Thank you, Mr. Chair.
Mr. Mann, can I just follow up on with reference to Ms. Newton's question real quick?
Absolutely, Mr. Chairman.
Yeah, and Ms. Newton, that's kind of what I assume on the number 4 when we talk about an approach. My assumption was that the question was from the members, you want us to pursue it and provide you with a phase-in approach. What do you think about that? So we can go ahead on and put together a phase-in approach for you to consider. That was kind of my assumption. So is that Mr. Brown? Is that what your assumption was? Is to just give us an idea that you think about a phase-in approach and what we think about a phase-in approach, or what?
Absolutely. So my idea was, for example, we believe, and I'm referring to my conversations with our team, our staff, that a phased-in approach would be a best approach. However, we did not want to assume that the council felt as though a phased-in approach was the best approach, because you all might determine that, if, as I determined it here, all or nothing approach is a better approach. So it was to have the dialogue to make sure we were on the right track as we thought about what we believe should be happening. And again, trying to marry what we thought should be happening with exactly what the policy makers want to see happen. So, I understand your question. So yes, we were looking for a phased-in approach. That would be what we would ultimately recommend based on all the things that we've seen. We believe that makes the best sense and gives us the best opportunity to be safe as we go through this process, while we also have the ability to be flexible and adapt to new information as it comes out. As you heard Dr. Gerard just say, things change rapidly. So we believe a phased-in approach allows us to accommodate all of those concerns and all of those issues versus a one day we're open, one day we're closed type of approach. So that would be
Mr. Chair. Mr. Chair, since you're still responding to my initial question, can I perhaps ask my question a different way?
Yes.
I apologize. Thank you, Mr. Manning. Thank you for your patience. I guess from my perspective, I feel like we're flipping this process a bit on its head. So while I think it's absolutely great and necessary for us to have a discussion as a body in terms of what we'd like to see about some of these things, I think the fact of the matter, as I understand it, is that you have already done research, you've already looked at standards. There are things that you would recommend to us as a body. So as opposed to pretending that you don't actually have thoughts about these things, from my perspective, it would be helpful if you said, these are the specific standards that we looked at. We thought that this standard seemed most applicable to Richland County, and or we blended these standards together because that seemed like a best practice for a county our size. We think these are the key areas that we need to look at. This is the approach that we specifically recommend that we take. How do you as a body feel about our recommendations as it relates to these criteria? And then we can have a conversation about that. And then later you can say, we made those recommendations to you based on XYZ standards. Once we took a look at the CDC guidelines, this is how we might recommend that you adapt it. I guess I just feel like we flipped it on its head. And so that I'm still unclear about what you are recommending to us as best practices based on what you've seen. That said, I acknowledge the comments of my colleagues previously about bringing in an expert to advise us on this process, but I guess I just feel like we've started this conversation on the inverse, and I'm really done now. Thank you, Mr. Chair.
Thank you very much.
Mr. Chair, parliamentary question. A parliamentary question.
Go ahead.
Did Ms. Myers not make a motion? And I didn't second it. I'm sort of, I got lost.
What was the
Yeah,
motion?
I thought we were asking to have some expertise brought in. You're right, Ms. McBride.
But I didn't realize that was a motion, Miss. I apologize. I didn't realize you made the motion.
You want me to state it better?
So, Ms. Myers, so you did make a motion
Yeah, I was specifically asking that we ask the staff to do those two things. Yes, sir.
Right, but I didn't take it as a
I
motion.
definitely
Though, that's
wanted
what I'm
us to
saying.
vote as a committee on it. I guess I wasn't clear. I'm sorry. That's my fault.
And I thought I seconded it, but maybe not.
No, I don't remember getting a motion.
Okay.
But we'll come back to that in a moment. I'll let Mr. Manners speak, then we'll come back and
Yes, sir.
after Mr. Manners is done, I recognize you, Ms. Myers. If you want to make a motion, you can make a motion. Okay, Ms. Manning?
Thank you, Mr. Chairman. Appreciate all the work of the committee and allowing me to speak for a moment. I think it's very, very important, and I 100% agree with Vice Chairwoman Myers about there are kind of two CDC recommendations. There's that public one, but then there's that second one that got pushed back. And I just want to make sure that we are all very, very clear that it is the not published set that we would like to see. Secondly, to kind of the parliamentarian question, I would suggest that the committee not make a motion, but give direction to staff, because if it becomes a motion, then I think you're going to have to wait for it to go to the full council, where if your committee makes a recommendation or directs staff to move forward with that for the sake of the committee's work, then the staff will be able to go forward with it literally as we hang up on this Zoom meeting. So I think I'd like you to consider that parliamentarian thought along the way. And then the last thing is that I am a little concerned in that we hire a professional county administrator to do the work, and, you know, guidance with things like, yes, we want a phased, not turn the switch on and 100% back. But at the same time, with nimbleness and as quickly as this is moving, you know, just being a little guarded over how much we don't empower the administrator to conduct the work of the county with, well, you know, go get an expert, do this and look at this and do something else. And then nothing happens till it comes back to the committee. Then based on when it gets back to the committee and the committee gets scheduled to when's going to be the next council meeting. And I just be a little guarded about how we kind of procedurally don't handcuff the county administrator by parliamentarian official motions and seconds, and then where that has to officially and formally go. And I'm done. Thank you for letting me say my 2 cents.
Thank you for saying your 2 cents. Ms. Myers, you recognize.
Thank you, sir. Mr. Manning, thank you for those extremely helpful comments. I actually quite agree. Ms. McBride, unless you disagree, I think Mr. Manning's right. We don't want to hamstring the process, but I think we do want it to be clear that it's the sentiment of this body that we need an expert helping us, and that there's some CDC guidance that the best experts in the United States have put together, and that's been hidden. And that guidance will tell us a lot of what y'all are trying to, God bless you, figure out to lead this county back to work. And I would just suggest then, unless Ms. McBride virulently disagrees, I would suggest strongly that we seek that particular guidance, as well as, and I agree with you, Mr. Manning, I don't want to be telling Mr. Brown that he can't move forward without this, that, and the other thing. The only caveat for this is, you know, it's as if there is literally a person with a machine gun on every street corner in Richland County, and he's trying to figure it out. I mean, he just does need the sheriff's department. In this case, the sheriff is an epidemiologist. And I just am nervous that we move forward with not a doctor or expert among us. So that's where that came from. And if the committee thinks that we don't need that, I'm willing to yield to the will of the committee. But in this context, because there is so much at stake, and Richland County has been the leader in a very bad way on this in the state, I'd like some serious guidance. And I'm reluctant even to say to Mr. Brown, yeah, personally, in Delia Myers' opinion, I think you're right. A staged opening, you know, where there is some staggering to it and people come in, some of them work 2 days a week, some of them in the building, some of them work 3 days a week in the building, and everybody does their regular job from home. That seems to make a lot of sense to me, but I'm not an expert on this. And I just think prudence says, and from a legal standpoint, we need an expert that we can rely on who can tell us specifically, these are the things y'all should do, in my opinion.
Mr. Chair.
Ms. McBride, you recognize.
Ms. Myers, I have no problem, and I agree with Mr. Manning regarding directing the administrator. As most of you know, I've sent out emails. I've mentioned it in council. I mentioned it in this committee that you just need an expert. This is a new area, and we need expertise in helping us make our decision. And I don't think that's something that's different from many other counties and cities nationwide. Thank you.
Is there, now, Ms. Myers, you want to put that motion?
We're not going to do a motion.
Yeah, we decided against the motion on the good advice of our colleague, Mr. Manning.
Well, and
but strong recommendation from the committee.
Well, I would add to say, at least for Mr. Brown's sake, keep in mind, not only this committee, but council have already given him the authority to, within his within his authority to get what he needs to help with this virus situation. So it'd be one of those situations. So I'm saying that to say then to Mr. Brown that if he agrees, if that's what he needs, that he has authority to do that based on, I think, council's previous decision.
Okay.
We are strongly recommended.
And the
Mr.
committee.
Brown, do you want a motion?
No, I don't.
No, I don't think we need a motion, but I agree to, you know, the committee is recommending that he do it, yes.
Yes, sir, Mr. Chair. I heard you clearly, and that's to Ms. McBride's point, and I've heard it expounded on today. That's one of the reasons why I tried to make sure that I reach out, at least for the purpose of this meeting today, and had those medical officials and public health folks on the line. But I understand also the request to go beyond that. And so just as we kind of, and I don't know if we're going to go through the rest of this agenda in terms of the order that, because I think based on what I'm hearing now, all of that would really come back from whatever plan, whatever guidance that the medical expert would provide, because all this is really tied to that.
Yes.
But one of the things I certainly wanted to just share with the body is, and I may have misunderstood what Councilmember Newton was saying. So if I did, Councilmember Newton, I apologize if I misrepresent what you were saying. But my thought is that as Richland County is going to have some kind of plan that is going to roll out to its employees and to its community, that it was important that the body be given an opportunity to speak to what they believe that plan would entail, rather than me deciding what I think the plan should entail and then giving it to the body without the body having the ability to be out in front and give guidance on that. So that's kind of why I was doing it this way. But if in fact developing the plan and presenting the plan should come first, then again, I'm okay with that as well. Just one of the things I know I've heard is making sure that you have the appropriate involvement of those who represent the people as you develop things. And so that's what this was an attempt to do. So that's why it may seem a little bit reverse. But my intentions were to, again, allow the body to speak, and then we move in coordination with that versus another approach. So again, I believe I understand better now, and I will respond appropriately based on that information.
Mr. Chair.
Mr. Chair.
Ms. Newton?
If I could just address Mr. Brown's last point as it was directed to one of my questions. I, number one, don't represent the entirety of this body, and I was not asking that you come to us with a complete plan that was signed, sealed, and delivered and ready for us to, vote up or down. That wasn't really my suggestion, nor was it a suggestion that we move forward in the absence of data. It was just an acknowledgement that, like we spoke with Dr. Bell, you've also spoken with others, that there were probably some broad strokes of what your current thinking was that you could outline for us that might be a bit more expansive than the list of words that I see on this agenda. So that's what I was suggesting. Okay. For example, if you said, the XYZ standard suggests that a phase-in approach is best for businesses, we wanted to get your feedback. What we were thinking that could include is, staggering work schedules, whatever the case may be. I was looking for more a broad outline of what your thinking was in this area. Okay. But I am not, as a single member of this body, trying to direct you to exclusively create a plan and then you just come back and we talk about it then. So we can address my question offline. Thank you, Mr. Chair.
You're quite welcome. Any further questions? Because
Mr. Chair.
4, 5, and
Mr. Chair.
I'm sorry. Ms. Martha.
Yes, sir. and just to Mr. Brown's comments, Mr. Brown, my comment as well was not meant to say that your approach is misguided. I like your approach. I appreciate that you came and said, let us please make this iterative. This is important. And please tell me what you think are important pieces of this policy so that I can go off and then put something together and bring it back before you. I think what you're hearing from at least me is this is an area that is so unique and the stakes are so very high that I think we need the kind of expertise that we just don't possess in Richland County. And I am reluctant to offer my opinion. I mean, I've been reading what other counties are doing. I've been following, best practices and all of that stuff. But I also don't know if those best practices have taken into account the situation on the ground that is similar enough to Richland County to make it a best practice for us. And in this context, and I think this is hopefully the most unique set of circumstances I'll ever face as a Richland County council person, I think in this context, I think it is a dangerous mistake to move forward without that kind of tailor-made epidemiological guidance for this county that we're asking for, and that, because the expertise exists in the United States and we can get it virtually free from the CDC, and then, find some epidemiologist who's qualified to help us with crafting something. I just think in this case, it's unique, and I appreciate what you're trying to do. That is, for me, what I hope we, going forward, always try to do. It's always more helpful to have some, input on the front end. So thank you for that. But just this is such a rare case that I think we may have some considerations that aren't normal here. Thank you.
Mr. Chair.
Ms. McBride.
I agree with my colleagues, and Mr. Brown, I certainly appreciate your efforts to bring in the different public health officials and experts, which was one of my requests. So I certainly appreciate everything that you've done. But on this particular case, I think that we need to look at the guidance from the experts. You bring together a recommendation, or just bring together some factual information and some suggestions. And then we will respond and we will have input, but it will be input based on factual information that we had. So that's the only, the real big issue that I had with it. Thank you.
Thank you. The comments particularly reference items 4, 5, and 6, because I think they're all grouped together. And 7. If not, the other 2 items we need to deal with is that was added, and that is an update regarding the and plan and so forth. The items. Mr. Brown, you want to provide us with that update in terms of the status of our relief program?
Yes, sir, Mr. Chair. What I'm going to do is I'm going to mute my mic here in a second and turn it over to Ashia to give you that update. I will tell you in general, we are just past the first review phase of our program. And so we do have some preliminary information for you that we can share. And then after the information becomes final, we'll be able to give you a more robust and documented overview so that you can have that for your information and for your review. So give me a moment. I'm going to mute my mic here and allow Ms. Myers to Ashia to speak.
Good afternoon, Chairman Lipstein, members of the council. Oh, sorry. Good afternoon, Chairman Lipstein, members of the council, committee, and members of the council. Again, Mr. Brown indicated these numbers are preliminary. We will give you just a brief overview of the efforts thus far. We have had 374 completed applications as of 12:50 p.m. today. There have been 819 applications started, but they were not submitted. So we have a large number that of people who may have began the process but have not completed the process. Of those, 374 have been completed. There have been 58 applications from community organizations or nonprofits registered with the Secretary of State, and then 317 applications from for-profit entities with the current Richland County business license. Moving on from that, both the nonprofit committees and the small business committees have completed their first round of meetings, and we anticipate disbursements being mailed out on the 21st of this month for the first round. That has given staff and the accounts payable people the appropriate time to enter the data necessary to complete that payment process. There are a couple of things that we have to go back to get from applicants because we did have some delays due to applications not being complete and or requested documentation not being provided with the application. Award notices will be mailed following verification of award amounts via email after those have been signed off and confirmed by the committees. For our nonprofit grants, we received a total of $952,931.98. Cumulatively for the requests, the average request was about $33,436, but that's just a cumulative total and average total, not a median or mean total. The largest amount of populations to be served were categorized as other, but that included the combinations of the categories on our application, which were senior citizens, residents without health insurance or paid leave, part-time seasonal workers, individuals experiencing homelessness, and healthcare workers. But majority of our applications for nonprofits indicated other because they either combined categories or they identified individuals with disabilities, children-specific populations, or low-income residents. Relative to our small business grants, the data for that is a little bit more comprehensive. The largest amount of applicants were either 1 to 2 years in operation or 3 to 5 years in operation combined, but overall, the largest category was over 11 years in operation with 37% of applicants thus far. The highest percentage for the type of business that we've gotten applications for have been salon and barber shops, followed closely by retail or service industries. And following that, applicants by association, which are our minority groups, we received majority that are a minority of some sort, and then it broke down further into either a non-minority woman or a minority woman or service disabled veteran. We are seeing about a 1% change in terms of employees prior to and after COVID-19, with most of our applicants saying that they will be using funds to retain their employees and or rehire, as outlined by our application. And that's all I have. Do you guys have any questions relative to that preliminary data?
Question.
Ms. Myers,
Yes.
Ms. Myers and Ms. Newton.
you gave an average number for the amount requested by the nonprofits, but not for the for-profits. What's that number?
I do not have that number readily available, but I can get that number to you. Most of them just requested the max. There are very few that actually requested a specific number.
When
But
you
I'll be
say they
glad to
just
get that average to you. Ma'am?
So you say they requested the max, and what did we list the max as?
$10,000.
And so there's no tailoring in there. They haven't said, you know, rental assistance for this month or next month. They've just come in and said, I need $10,000.
Yes, ma'am.
Okay, and when will all the vetted responses or the approved responses be brought back before the body?
I will coordinate that with the Office of Budget Grants Management to see once that information is available.
Thank you.
My pleasure.
Mr. Chair.
When you say before the body, you're talking about the council, the committee, what body, what do you refer to?
The council, the
Okay.
council.
Okay, thank you.
Mr. Chair.
It's Newton and then right.
Thank you, Mr. Chair. Ms. Myers, Ms. Ashia Myers, thank you for sharing that update. Unfortunately, my note writing was not up to the task of keeping up with all that data. So my request would be, in addition to the additional information that you are researching, can you send that to us in writing so that we have that overview?
Yes, ma'am, certainly may. Certainly will.
Thank you.
Ms. O'Brien?
Yes. I wasn't able to keep up with the note taking either. So that would be helpful if we got a copy of the information you provided. For the small businesses, you said checks were being cut, so I'm not quite understanding the checks being cut, and then we're reviewing the applications. So could you help me there?
No, ma'am, I didn't say that checks were being cut. I said pending the final review by the committee of the amounts to be dispersed, then we'll follow through with disperse it with the anticipated date for disbursement being the 21st.
Okay, so have we met the deadline, the cutoff date?
Yes, ma'am. So the council approved a rolling deadline. So the committee is reviewing the applications approximately every 14 days as they come in. So the first deadline was last week, and then
last week. So we had a cutoff for last week.
Yes, ma'am.
And based on last week, how many applications? I guess it'll be able to show the one for the small businesses and then the other for the nonprofit, because I was sort of getting the two mixed up with my notes.
Yes, ma'am. It was 317 for the small business and 58 for the nonprofits.
Okay, 317 for the small businesses. Okay, and out of those 317, how many are we anticipating funding, or have we not gotten there?
That information has not been provided yet.
Okay. All right, thank you.
My pleasure.
Mr. Chair.
Who's that?
This is Shakise Newton. May I ask another question?
Ms. Newton and then Livingston.
Ms. Myers, and this might not be possible, but I am curious, now that you have gone through the first round of this process, as I recall in the committee, what we discussed was that we would continue to tweak the process as we move forward. Are there lessons learned about the process that we've been using, or questions that we've been asking, or different ways that we might administer this so that we can improve upon the process for our constituents? And also for the county in terms of making it easier for us to review and assess the information that we've been provided.
That is a question that I cannot answer with any level of certainty. What I can do, though, is ask the Office of Budget Grants Management for any feedback that they have received from members of the committee, from staff, and then from the applicants themselves relative to the process.
Can you put that in some kind of report or something, some kind of format for us?
Mr. Livingston, I actually do have Budget Director James Hayes here, and he's going to reply on some level to Ms. Newton's comment. But yes, we can put that in writing for you at your request.
Thank you. Mr. Hayes, you go ahead and respond.
Yeah, good afternoon, Chair Livingston and members of council. Yes, one of the biggest things that we found is just the time for the actual review committees to review, initial time that they were given, which we estimated to be about 4 days. The feedback that we got for them to be able to do, because of the volume of the application we got, it was not enough time. So going forward, we're trying to build in a couple of extra days so that the reviewers have accurate amount of time to review these applications, so that scoring they do is not only fair, but consistent, and making sure that it follows all the guidelines. So that's the biggest thing that we found from an employee standpoint. We got tremendous, thanks to ACA Power, we got tremendous help in terms of the Office of GCS and OSPO helping us with the process of reviewing, staff reviewing applications before the committee. But what the issue was with the committee was actually the committee needing a couple more days to fairly review those applications. So I would say that's probably the number one lesson that we learned going through round one.
Mr. Chair.
Ms. McGrath.
From the grants office, Kyle, does he have any input in terms of the questions and the problems that the individuals had in trying to complete the application? I
Yes,
heard
ma'am.
from a few
Yes,
that.
ma'am. Good, very, very good question, Ms. McBride. Yes, that's it. He does. They actually, if there's a question, we have an email that's set up from a technical standpoint. If they're having some issues with a technical question, there's an email that IT set up that is monitored that we reach out back to them. Plus, also if they're having questions allowed specifically with the application, other members of my staff reach back out to them to help them. Yes, ma'am.
Okay, I have heard had some concerns regarding the process being a little complicated in completing the application, and particularly in one area, and I can't recall that area. I can't recall the area. I need to go back and check my notes. That I did receive a few calls on it saying that the process was really complicated in trying to develop future plans and trying to do a projection of each cost for the future plans. It was a little difficult for these individuals, particularly the small businesses that never had to fill out a grant application before.
Yes, ma'am. I understand. I think when admin was trying to do the application, they definitely did simplify it a lot. But obviously, this is trial and error. So if there's something that we can change going forward, we certainly more than happy to take a look at it.
I would appreciate that. Thank you.
Thank you. Just one quick question. Ms. Myers, you mentioned, well, $10,000 is the maximum amount, and you said most folks were applying for the maximum amount. Is that an all or nothing? In other words, do they get the $10,000, or are the committees looking at the application and say, well, this is a $5,000 application, whatever? How's that being decided?
So they, to my understanding, and Mr. Hayes can correct me if I'm wrong, they will award a percentage. They even if they're not going to get the $10,000, if they are eligible for a reward and they get approval, they'll get a percentage of that.
Okay, so it's not an automatic $10,000 because you approve it.
Yes, sir. It's based off the scoring.
Okay.
Mr. Chairman.
Ms. Myers, you recognize?
Thank you, sir. And just Mr. Hayes, a question following up on what Ms. McBride asked. I received several queries and with some level of confusion as to the need to demonstrate a loss for 6 months related to COVID-19. Is that actually a question?
That's it, Ms. Myers. That was the one.
Okay.
Say that again, Ms. Myers.
Okay, hi. I'll answer that question.
Several emails and requests from small businesses, a myriad of businesses, law firms, sole practitioners, beauty and barber shops. One was a masseuse who owned a spa, and they all focused in on what they should do with some question that asked them to show 6 months worth of losses related to COVID-19. And my response was, fill out the application and answer all questions, and, state that we haven't been in COVID-19 for 6 months. You can state, where you are, but that would be near impossible because we haven't been here for 6 months. So I'd like some understanding of whether or not that's a question and sort of the logic to it.
So there's not a question that asked them to provide 6 months worth of losses. So I'm slightly confused at what application they may be looking at that says that, but the application itself does request average weekly revenue prior to COVID and then average monthly revenue prior to, and then the current weekly and the current monthly. So we're not asking for 6 months of data. We're just asking for the average prior and then what the current is as points of comparison. We do ask them to provide a brief description of how COVID-19 has adversely impacted their operations, but there is not a request for 6 months worth of data itself on the application.
That must be some misunderstanding because I got it from multiple people. And, I haven't seen the application. I clearly have no way of coming up with that as a concern, but I got that from several people. So maybe they're looking at the wrong application. I don't know, but I think I circled back with you all and asked if, what they should do if they couldn't demonstrate 6 months worth of losses. and someone directed me to direct them to Tyler Kirk, so that's what I did. But that was a question that I got at least 4 times. So something in there is making them think they have to show some level of loss for a period of 6 months. Now, it may not be phrased exactly in those words, but that's the sentiment from all of those different questioners.
Yes, ma'am, Ms. Myers. We will take in, if there are any questions, we'll be glad to answer them. But as a note, all the questions that we've asked, and particularly some of them are required for us to receive any form of federal reimbursement. So that's why many of the questions are included on the application that are there. I'll go back through and look through perhaps the guidelines to see if they're getting any of the miscommunication there about a 6-month window for loss. And make sure
right, or maybe just the way we're phrasing it. I mean,
yes,
obviously they got to follow the guidelines. You're right about that.
Yes, ma'am. I'll make sure to go back and look at that and change it as necessary so that we're much more clear and businesses don't feel that burden.
Thank you.
My pleasure. Are there any other questions relative to the grants update?
No, I just wanted to add to Ms. Myers, I had several people contact me, businesses contact me with the same question.
Yes, ma'am. Well, that will conclude.
Thank you very much. Any other questions regarding the update? If not, that brings us to other items.
Mr. Chair, Ms. Myers is going to email that information to us. The report, is she going to email that information to us?
Yes, ma'am.
Yes,
We'll send it.
Thank you.
Ms. Newton, what did you have in mind? Did you have anything particular in mind, reference other item?
Mr. Chair, I had no idea where this meeting was going to go, and so just wanted that item as a placeholder, but I do have a question.
Mm-hmm.
We started with our health experts talking to us, and they addressed testing quite a bit in terms of what Prisma Health is doing, in terms of what Deaq is doing. Is there anything in addition that we as Richland County are doing as it relates to testing, whether that is testing for Richland County citizens or testing for Richland County staff?
I'm not aware of anything specifically that we're doing for testing, but following up on the conversation regarding Ms. Bell in terms of and Mrs. McBride's questions to Ms. Bell, I think it's important for us to figure out a way to interact with them and whomever else and talk about and figure out what role we could play to enhance the probability of testing in our community. Whether it means we have to provide some additional resources or whatever it might be, I just think we need to at least look at a means of figuring out how we can address that issue for Richland County more specifically.
Thank you, Mr. Chair. Is there any additional information that our administrator has, or is that the final word on testing?
Councilmember Newton, in terms of testing, in terms you asked two particular, I think, questions. One about community help, and then one for employee-related testing. I think the employee-related testing would fall under the overall plan for how we would look at reopening. Community-wide, or additional support in the community. I've had some conversations here with Mr. Ford about some of the things he shared with you all about their plans for potentially bringing additional testing resources to the community. And I've asked him to give me some information, which is one of the reasons why I wanted him on this call as well. And so he has not given me any additional details related to how and when they might actually put those testing sites out so that we could share with you all. And at this point in time, we have not identified, at least at this moment, available funding to immediately provide an additional level of testing beyond what is currently being provided by those outside resources. And then the second part of that is as we're looking at what testing possibilities may exist and for who we can partner with. I did have a conversation a while ago, and this was I'll certainly give credit to Councilmember McBride. I did have a conversation with the mayor related to a IGA that they had potentially forwarded to me that we could look at if in fact Richland County decided to go in and begin purchasing, testing, and utilizing that in some fashion, utilizing the provider that they had identified. So that is something that I do have. But again, as we go through this process of understanding how we want to test and where we want to test, and then again, what additional support we want to provide to the community, those are things that, hearing this committee talk and hearing the council speak, those will be additional considerations that we will partner with other agencies. So from those two perspectives, employee-wise has not been decided. There are certainly some different thoughts on that, but I don't know what the updated CDC guidance is. And then from a community standpoint, I have heard council talk about wanting to be able to do that. I do know that there's still a limited supply of testing right now. But I do know that we're working with other partners to make sure they're aware that we want to be involved in that process.
Yeah, I think the idea too, when we talk about the possible resource person you may find to help, that's something I think that resource person can help us with too, is some ideas about testing. So I would put that on that person's agenda too.
Yes, sir, Mr. Chair.
Mr. Livingston?
Ms. Myers?
Can I just ask if it's possible to set some dates for this committee to meet and some targets for us to have updated so that we can begin moving in a more systematic way to figuring out how we're going to reopen the county, what that means for the broader citizenry, so that we're not just sort of having this haphazard meeting schedule that just sort of pops up, but we have a meeting schedule set and we and staff are working towards those dates in terms of checking things off of a list and getting things done. Because once we put those hard dates in, we at least know that we're going to have updates on some regularized schedule that forces some of these questions to get answered sooner rather than later.
Yeah, we talked about that one time before. We just didn't set a date. I think that's a great idea. Just to set a date for once a week, every week, and just have a standard date each week. So let's look at some suggestions for a standard day and time. If we need to change, we'll change it, but at least we have something to shoot for.
Mr. Chair, that previous conversation, I apologize. This is Shakise Newton. Am I recognized?
Yes.
We did discuss that before, and the request was just, is that something that we could coordinate offline as opposed to spending our time here playing dueling calendars? So I absolutely support that recommendation.
All right, and I'll get something out to folks no later than tomorrow to try to look at some possible day and time.
Mr. Chair?
Yes.
One last request.
Mm-hmm.
When those requests go out, can we please have more than one option? Ask for dates and times, or just maybe ask people to submit some, but when it comes out and it's just, this is the day, it throws a wrecking ball into a lot of schedules.
No, I wouldn't send anything out and say this is the day.
Mr. Chair.
I apologize.
Yes, Ms. McBride.
You asked about other issues, and one was with the health disparities, and both Dr. Bell and others, and I think we as a council had mentioned it. How do we get the message out to those communities that are having the health disparities based on underlying health conditions and other chronic illnesses with COVID-19. Dr. Bell mentioned a special messenger that we could use to direct at various communities. And my question is, what is the county doing, or what should we be doing in that effort? Because we have not done anything yet in terms of getting the message out.
Any questions, feedback in reference to that? I remember one time some of y'all were talking about, we mentioned something about even sending postcards to folks and something different, special, you know.
I know, but nothing was done, no follow-up or anything.
You know what I'm saying? It just some ideas going back to remind me of some things. Yeah.
Well, Mr. Chair, relative
Mr. Chair. Oh, sorry.
No, go right ahead, please, council member.
No, sir,
Yeah,
go ahead.
No, I'm simply going to communicate that in reference to those health disparities, those zip codes, I believe that you referenced, Ms. McBride, and that were referenced by Dr. Bell. We can get those information from them to make sure that we have that information. And then we can make sure that, I believe what you're asking is for us to point those folks to available resources that they may need to be aware of related to COVID-19?
No, that's part of it, but no, but my message, my issue was getting a message that is appropriate for the communities, that they're listening to the message that we're putting out in terms of social distancing and you know, hand cleanliness and all those other things, but there's a way to message this.
Okay.
It's actually education, public education.
Okay.
In addition to what you were saying about resources.
Yes, ma'am. Okay.
Mr. Chair.
Ms. Price?
Yep, I just want to agree.
And I apologize.
Oh, I'm sorry. Go ahead. I thought I was after Mr. Brown, but I can wait.
No, I was just telling Mr. Mann, I didn't see his hand up, but I was calling him next.
Okay.
Good.
I wanted to just chime in and agree with Ms. McBride. I was going to say the same thing that she just said, which is, I think she's talking about an aggressive public education campaign. Richland County is leading the state in diagnosed COVID-19 cases, and we're sort of sitting back waiting for Deaq to tell us to do something, or waiting for the governor to tell us to do something, when in fact, we could even be buying a bunch of billboards that say, Richland County reminds you to wash your hands. Richland County reminds you to stay 6 feet apart. Richland County reminds you to stay at home if you don't have to be out. I mean, just plain old, you know, reminders, public education that keeps before people the fact that we are leading in a very bad way. And I think that, you know, Deaq has got its hands full with the whole of the state. So does Dr. Bell. Our job is Richland County. And sending a postcard is great, and I think we could do that. But having a constant reminder to the whole of the county that these things are critically important, and in some cases could save your life, I think is one of the highest priority things we need to be doing. And so I wholeheartedly agree with Ms. McBride that we need a public education campaign going, that we need it yesterday. And I might also suggest, and Mr. Brown, you can chime in and agree or disagree, but, you know, I know we were sort of wanting to do the teletown halls with the library, with whomever. Mr. Brown can attest to the fact that Richland County residents want to hear from us. We did one with literally nearly 1,000 people online. Perhaps what we need to be doing is using this time to, you know, take advantage of that format and get on the horn and tell people, you know, how they can get county services, what we're doing for COVID-19, talking to the business community, and not sitting back, you know, sort of and waiting around. I am personally just a little nervous that we're not doing enough, A, to educate, and B, to lead our citizenry during what is a really strange time. Thank you.
Thank you. Mr. Manning?
Thank you, Mr. Chairman. Along with what Councilwoman Newton was saying, I too would find it very helpful if we could schedule a regular time. And, you know, last time started doing it on the call and that seemed cumbersome, but then it didn't get done. They do have a thing called a doodle poll that is very simple to use and might look at utilizing to go ahead and find out what works for the committee members and get standard times locked in. Thanks, sir.
Thank you, sir. Any further questions reference that other item? And Mr. Brown, you understand the main point of that other item and looking at all different options, you know, billboards mentioned, cards, town hall, even I think for a lot of our constituents in some areas, we're talking about radio would help. You know, county announcement on the radio or something. But just looking at the best avenues for our community.
Yes, sir, Mr. Chair, members of council.
The final question, Mr. Chair.
You recognize Ms. McBride?
This is my final question.
No, it don't have to be a final question, though.
What is the status of the contract with, I can't think of the company's, Tetra Tech, yeah.
Yeah, the status of that task order was approved and has been signed and authorized. So that's the status, so that we have engaged them.
Are we working with them now? Are we meeting with them or what?
Yes, ma'am. We are.
And so have they been involved in our discussions regarding the perhaps looking at the reopening of the county, bringing back employees? Have we involved them in any way?
Not to the detail, without having done what I was trying to do here first, but we are engaging them. Yes, ma'am.
Okay, thank you.
And we'll, Mr. Brown, and make sure that be one of the updates for our next meeting in terms of Tetra Tech.
Okay.
To where.
Mr. Chair, I'm sorry. That promised to be Ms. McBride. This is my last.
No, I don't want any promises. Go ahead. That's why we're here.
Sorry. With regard to one of the things that we started with some time ago that hasn't gotten any traction, the notion of putting together a Richland County or countywide Blue Ribbon Task Force to lead the recovery efforts. We haven't peopled that or even discussed it since the beginning of this ad hoc committee's discussion. So I'd like to put that back before us. I think that we're sort of lagging behind at this point, and we do need something like that in place. Thank you, sir.
Now, you referring to a citizens task force?
I'm referring to a hybrid task force. No, not like the Kenny Advisory Committee, but more like the flood recovery effort with the Blue Ribbon Task Force.
That's what I mean.
Yes, sir.
Okay, we'll put that on the list too. Anything else?
Mr. Chair, is that something Tetra Tech, they're very familiar with, that they could assist with? Because I know staff is on overload.
Yes, I think they could, yeah. Based on their previous experiences.
I think that's a good idea, Ms. Myers.
Thank you, Ms. McBride.
We'll certainly follow up on that.
Mr. Chair?
Yes,
I move to adjourn.
Second.
Move to adjourn. It's a proper second in discussion. If not, Ms. Roberts, going to call roll for adjournment?
Yes, sir. McBride,
She's doing yes, sir.
Livingston,
Yes.
Myers,
Yes.
Newton.
Yes.
It passes.
Thank you, everybody, for a very productive meeting. We'll continue to move forward. We'll follow up on items that we said we will. And everybody have a great evening.
Mr. Chair, thank you for responding to my email.
You're quite welcome.